Hello, ladies and gentlemen, and it's my pleasure to welcome you to the panel discussion associated with the symposium focused on the London classification and the investigation of anorectal disorders. Now, this is an exciting time in this field. This is the first time that we have a consensus classification that allows us to investigate the physiology of those very important few centimeters at the end of the bowel, the centimeters that allow us to control ourselves when it's important and to go off to the toilet when we want to. That's if we're lucky. This panel discussion will talk about the investigation of people who are less lucky than hopefully most of us listening this evening. There will be two sections. This first section is focused on the London classification itself. The second section will focus on the clinical investigation and will be chaired by my colleague, Maura Corsetti. Without any ado, I'd like to thank all of you for being here, and I'll turn now to Emma Carrington, who gave the first presentation and was one of the key people leading this process. So Emma, welcome. And the first question on my list is, well, congratulations, of course, but what do you think? What's the most important part of the process? How did you experience it? What really got the ball rolling? What was the key part of reaching the first consensus agreement on a classification of this kind?
Thanks very much, Mark. That's very kind of you, and thanks for the invitation today. The process of the London classification was really exciting because it was the first time really for 20 years that we as an academic and clinical community had really got together to discuss, debate, and to move the process of anorectal function testing forward. If you ask me what I think the most important part of it was, I think it really was involving experts, colleagues, friends, clinicians and academics from around the world so that each could give their own opinion on how anorectal function tests worked in their country and the nuances that we see internationally. Because before we started the consensus process, we performed a survey questionnaire to really find where the field was. The field was at baseline, and we surveyed 109 centres, and we found that of those 109 centres, there were not 2 centres who performed an identical protocol and reported the results in the same way. So we had a long way to go right from the start. So we really needed to have as many opinion leaders and clinicians in the process from the beginning, and I think that's really what has made it so successful. I think the second part of it was the rigidity of what we considered to be consensus. And we had a number of rounds of consensus because there was never going to be complete agreement moving forward to beginning. So we had quite a rigid structure which we followed to make sure that what was acceptable at the end was acceptable to almost all of us. And I think those are the two main things that I think really made the classification itself a success.
No, in my memory, we had some extraordinary meetings where we argued about terminology. Can you remember discussing the meaning of the word urgency for more than an hour in Barcelona? I mean, I really think that just agreeing on the words.
I think it really shows the strength, Yeah, absolutely. And I think that's absolutely key to the reason why the London classification was important. We all performed the same investigations, and yet until 2019, we're all doing them completely different ways, analysing them different ways, and calling them different things. And so it's very difficult to unwind a lifetime's worth of a lifetime's worth of experience, and to move with something that you're unfamiliar with. But I think that the group of people that we had, were not only very passionate about anorectal function tests, but were also, great human beings who were all willing to, come to some kind of middle ground and consensus in the end. And so I'm pretty proud of us that we managed to get something out, because at the beginning it looked as though it was going to be a pretty difficult job.
It felt hard at the beginning. Do you think just the very fact that we've reached consensus is the main achievement, or do you think that this is genuinely a good classification, something that can be used in clinical practice. And I mean, others around in the forum here, I'd be interested to hear your feelings on this part too, because Emma and I may be partial.
I think that there is absolutely no doubt that reaching a consensus has been a real achievement, and that we have all, we've all put our names to what we would agree to be a minimum standard. But every consensus is only as successful as its dissemination and its utilization by the clinical community. And that is exactly where we are right now. If you ask me about that parameter of success, well, the London classification has been cited, I think, about 80 times since 2019. So people are actually reading the document, and they are actually starting to think about what it means and utilize it. However, I would be lying if I said that every paper that describes anorectal function tests has actually used the terminology in the classification. We haven't quite seen that uptake yet. And I think it's going to take a little while for us to see that effect. Now, that could be for a number of reasons. It could just be because reviewers of research articles, are not yet familiar, with the new standard. Or it could mean that the London classification has little bugs in it that we need to move forward on. And I think that we as a group need to just be mindful of the fact that this was just our opinion of where we needed to be right now. It was a starting point, and that I have no doubt that it's going to have to evolve as time goes on. I mean, that's just part of any sort of agreement. We really are looking at the first step. And, if people are reading it, then, even if they're not taking on 100%, I think that's a small achievement, which we can congratulate ourselves for a little bit.
We can only improve on the variation of practice, given that there was complete variation of practice to begin with.
The bar
Rebecca,
was low. The bar was low to begin with.
Rebecca, Maura, I mean, you do a large number of these studies. Do you intend to apply the London classification, and do you think it works, or do you think it's problematic?
I go first, if that's okay. Look, I think it is, as Emma said, a fantastic first step. And without that consensus and without that consistent way of performing these studies, we really can't move forwards. So it really is essential to the field to have that. Now, is it going to evolve over time? Absolutely it will. And, we now have the ability to test the classification properly in large studies, see where those gaps are and move forwards. And I actually think that's one of the greatest thing that's come out of this process of having that ability across centres to really be able to dig down at what the gaps are. It was a lively process, shall we say, but particularly with a condition where there is a lot of subjective pathology, for want of a better word. It's voluntary testing, even though, yes, there was a lot of discussion about urgency for a very long time. When you're looking across multiple different languages and people's presentation of symptoms, it actually was a really important process to get that consistency so we can move forwards. Otherwise, we would have just been feeling around in the dark for this area, and it's a fantastic first step.
Maura?
So I have to comment that I think it's very important, the standardization, because a problem that is common to all this anorectal function testing is the lack of standardization for all of them. So I think it's a very important first step. And I think that, Emma, you commented on the fact that this was also an opportunity to come together and to really probably stimulate research and work in putting together the different centers. So do you actually have already studies ongoing, multi-center study that are really trying to see whether this classification will improve the clinical practice or not? Or do you have something already? Can you tell us something about this?
Well, we do definitely have planned such studies to have a look at the introduction of the London classification and how that has impacted practice. But I think that the COVID sphere has kind of delayed that a little bit more than we expected. What I can tell you, though, is that I have continued to lecture virtually and teach virtually on anorectal function tests. And at absolutely every single meeting I speak at, somebody in the audience comes up to me and says, I just want to say thank you very much for the work that you've done on the classification, because for the first time, not only are my traces starting to look standardized, not only am I able to interpret them, but also I have a way of attributing a meaning to what those traces are finding. And I think that often those of us who do these investigations all the time forget that a lot of these studies are performed in clinical centers where anorectal function tests are perhaps only performed a few times a month, or even, a few times a year. And the clinicians who are interpreting them often are concerned about the impact of the variation of normality, the influence of multiple different pathoetiologies of symptom generation. And, we really have attributed meaning for the first time. So do I think that we're going to be able to completely characterize the mechanisms of continence and, and, make a game-changing, discovery? I think that is unlikely. But what I really think that we'll be able to do is we'll make a big improvement on raising the standards up to a common level so that people can discuss their investigation findings, and that those who are new to the field can interpret their studies more easily and learn more quickly. So yes, the plans are in place. I think we need a little bit of time for that to really seep out into the community before we can look for those changes, but I think the early signs are relatively promising.
Okay, very well.
One thing that I get asked about quite a bit are reference intervals or normal values in normal parlance. You've worked quite a lot on such matters. The normal values are quite wide, but we didn't choose to be very clear about reference values in the London classification, which is one thing which makes it slightly different to the Chicago classification, for example, of esophageal disorders. Where are we with reference values, with normal values?
So Mark, I don't know if you really want me to answer this question and whether you want the official response or my actual personal one, because I think you already know that I have a very personal opinion about this. And that is, the general received wisdom of our group at the moment is that normal values should be based according to, age, gender, parity, and that anyone who is continent has normal sphincter function. My personal opinion is that is actually not the case, because we know that symptoms of incontinence are often multifactorial. And just because a person is continent does not, in my opinion, mean that they have a normally functioning sphincter. And so therefore, I don't personally think that our normal values should be defined on age. I don't think they should be defined on parity. I think they should be defined according to an ideal standard, similar to, for example, bone mineral density and the definition of osteoporosis. If I had my way, and I know that this is not necessarily a very popular opinion, I would be basing normal values on those young nulliparous adults who've had no history of any sphincter injury. And I would be looking at how much an individual with symptoms sphincter function differed from that. Instead of how they compare with someone of the same, age and gender who was continent. So there was a lot of discussion about this during the consensus, and everyone had different views. Everyone used different kit. People talked about the influence not only of sex, sex and parity, but also the influence of body mass, of the influence of ethnicity. And so it became just so complicated that we felt as though the process was not going to move forward fast enough for us to come to a decision on that. And so we took a little bit of a backdoor route out and said that normal values should be based on, published studies using the same equipment, or indeed on local, on smaller local studies. But there's a lot of work to do there, and I would love to do that. I would love to really start to think quite carefully about exactly what we consider to be normal anal rectal function, and how how each part of that complex changes and how that influences symptom generation. I think that's a really fascinating area of research, and something that, when I have the time, I'll do.
Well, Anton Emmanuel is clearly working on something similar. He showed an interesting sort of vector diagram, which is something that Henrietta and I are trying to do on about 2,000 cases to see what kind of groups, phenotypes come out. Watch this space. There is a different approach. The approach of the Chicago classification is actually not so much to focus on what is normal as to try and define clearly abnormal levels, not levels that are never seen in health, levels that are fairly clearly associated with pathology. So the integrated relaxation pressure of the esophageal sphincter, if that's over 15, that there's general agreement that's fairly clearly abnormal in if it's consistent. This is a different approach. What do you think about this?
I think that it's a lot more oh, sorry, Rebecca.
No, go
first. No, not at all. I mean, I feel that I'm going on, but I think it's a lot more complicated in the anorectum for a number of reasons, because I think behavioral, lifestyle and behavioral features really impact on the frequency of symptoms, as does stool form, as does sensitivity of the rectum. I think there are so many other things that impact on an actual symptom, such as incontinence frequency or evacuatory difficulty. A patient's experience of those symptoms is so variable that if you were to choose a pressure or a pattern that was only ever seen in every single patient who had symptoms of continence or constipation, you would find yourself with a test that was essentially meaningless, because I think that not only would their symptoms be so profound, the test probably wouldn't have much additive value, but you would know by their clinical history that triage to treatment was necessary. So I'm not sure whether I really am on board with the fact that that would be useful in this field, but I'd be interested in everyone else's opinion.
Oh, you may.
My
Rebecca,
point of view, and jump in with that, because one of, as we know from the presentations earlier, the biggest challenges with this field in anorectal physiology is that overlap with health. So the other way of looking at it a little bit is, rather than saying that this is a disease state that we're finding, it's that this metric is an opportunity for treatment, because there is such an overlap of factors that are contributing to symptoms here. And Emma and I have had long discussions really over the last 10 years or more now on normality in anorectal function. And I must admit, I'm a very strong believer that it should be normal data in young females that have not had trauma and insults to the pelvic floor, because certainly in my clinical practice, I will see older patients with multiple children who apparently are continent but have quite significant dysfunction on testing, and perhaps they're only 1 or 2 steps away from developing symptoms. But actually being able to compare from what we know is a pelvic floor that has not had trauma, has not had damage, to a patient that is presenting with problems, what are the key things that we can target with therapy? Is there a dysynergic pattern there? And maybe we do see that in healthy individuals who otherwise are compensating for that with all their other mechanisms. But in a patient presenting with symptoms, other factors are impacting, and that therefore is now a target for treatment, even though it's a pattern we see in health as well. So I think stepping away from some of the disease definitions and treatment target definitions is likely to be more helpful.
Yes. No, I mean, this is really the space where until we get some kind of agreement on normal values, I think that there will be less rapid pickup of the classification, any classification perhaps, than we saw for example, the Chicago classification of esophageal disorders or the Lyon classification of reflux disease. People do love, I mean, good jobbing working doctors love a normal value because they know then where they stand, and that's, but it is certainly difficult. Also, I mean, Maura, perhaps, I mean, you are focused on the colon, and just out of curiosity, you know, where are we with the colon? Are you getting closer to being able to define very clearly abnormal and normal in that part of the world? Because of course that's clearly important, but we haven't dealt with that yet.
Yeah, well, not really, I would say, for one particular reason, that if it's difficult with the anorectal manometry to get the normal values, but of course, now that you have the standardization, you can probably put center all together and really probably reach a high number of patients and really healthy subjects, and really define probably the normality. With the colonic manometry, unfortunately, this is quite even more difficult, because first of all, we didn't agree yet on a standardized protocol to really perform this kind of evaluation. The centers that are able to perform this kind of evaluation are really few, and so at the moment the published study are really with numbers of patients that are, well, maximum 15 or something like this. So I think that is really a big jump. I think that definitely what you are doing now for the anorectal manometry, standardizing the procedure and try to agree and put together the relevant center to really guide the field, is something that we should be doing also for the colon, definitely in the future, and hopefully maybe with techniques that are less invasive and you can apply like the MRI more easily to many more patients and healthy subjects. This would be definitely the aim and what we are looking for.
I guess the nice thing also
Sorry.
the colon is you don't have to worry about patient effort and the voluntary component as well, which is the other challenge that we see very much so with the anorectum.
Actually,
yeah.
that brings us very nicely on to perhaps the second part of this assessment. I just want to bring Ugo you into this briefly. I mean, clearly the biggest difficulty that we have, I would say, is the assessment of anorectal coordination, and you no doubt you talk about this in your in the main program, and it's going to be a main topic of a major topic in the next half an hour. But just in terms of the London classification, Ugo, do you have any comments about how we deal with this? And do you think it's ever going to be possible to diagnose dyssynergia on manometry alone using these classifications, or are we always going to need a check from another test of defecation?
Yeah, well, I wanted to answer your first option, but I cannot. So I am definitely I definitely support a second confirmation by a different test from manometry. Given that, as we all know, manometry is a test of coordination, and patients lie in the left lateral position, which is not a natural defecatory position. So given these barriers, as we showed in a study comparing the defecatory maneuver between healthy volunteers and patients complaining of constipation, that the evidence of dyssynergic patterns were as high as in both groups. So actually, the type 1 dyssynergia was even more prevalent in healthy subjects than constipated patients. So it's a test that has definitely a lot of barriers if we choose to perform this as the sole test to get the diagnosis of dyssynergia. So I would definitely support the use of defecography associated with manometry or balloon expulsion test.
Thank you very
and
much.
which of the two, Ugo, if you have to choose two technique, you have the anorectal manometry, which one would you choose? Looking at the literature and
thank you for prompting me to say that I strongly support the use of defecography.
Can you explain us why? As you might know, I'm a bit critical in this, but
yeah. I feel that it's the only test that at the moment can give us a picture of possible functional and anatomical abnormalities in a same in a same setting. It's the only test that can give us a comprehensive assessment of the pelvic floor. Even if, in terms of radiological alternatives, especially here in Treviso, we have quite a large experience in the use of 3D echo defecography, so a transperineal ultrasound, which we use as a screening test before indicating defecography. But yes, I strongly support defecography as test of defecation.
And what the other things? Because recent study, meta-analysis or data from the literature really are going in the direction to suggest that probably combining a anorectal manometry with the balloon expulsion test, you have a kind of good evaluation of the anorectal function and also of the defecation process. And then you can probably reserve the defecography or the MRI defecography to those patients that you think you are really selecting for a surgical operation, because in that case, of course, the surgeon would like to have a better idea of how the anatomy looks like. And also thinking that the defecography, if we skip for a moment the MRI, as radiation, so as some kind of invasive approach for this patient. What do you think about this? I would be interested in the comments from Rebecca and Emma that I think, probably.
I can jump in there first. We in our centre have got both anorectal manometry and defecography available, although it is as a conventional defecography. My approach, and a little bit harking back to what I said before, is to use anorectal manometry. And the reason I do is because I'm looking for that treatment target and whether there is a pattern on defecation that I know I can modify with biofeedback that is going to improve their overall function. And it's really a kind of ruling out evacuatory dysfunction that I'm looking for. So, and ruling out whether there is a target for my pelvic floor physiotherapists to really look at. You know, in a patient that I've got signs that there is problems with evacuation and their normal pattern on manometry, then yes, I'll be definitely going for defecography, wondering whether there could be a structural contributor as well, and also to kind of confirm my manometry findings before I say, well, maybe biofeedback is not the best treatment for you. We need to go more down another path here, whether that's surgical or whether that is actually just general overall management of constipation. So I think the manometry is really useful for that kind of treatment target that we're looking for. We have a treatment that is focused at correcting a physical maneuver and muscle function. So it doesn't make sense to test that muscle function and see whether it is normal, because if it's already normal, we may not really get that much benefit from targeting it.
But do you use balloon expulsion at all, Rebecca, as part of your,
I don't use it routinely, I must admit. I go on symptoms and I use the manometry to look at the pelvic floor pattern. I do it in some patients, but I look at symptoms first, manometry, and then if, in spite of their still significant symptoms, they do have the features on manometry, then we would go to proctography. Yep.
No, sorry.
No, I mean, I
No, so-
also use
sorry.
manometry as a screening test. I do use the balloon expulsion test because I do think it's very helpful to confirm the impressions. I am, however, very convinced that we can do a far, far better job. I think all of these statistics of 80, 90% anismus in health, it's absolute rubbish. I see nothing like that. But
Me
I'm also
neither.
aware, that I must be looking at this in a different way to other people. And that's why, and I want to bring this part of the conversation to an end now. That's why I hope you all take part in my inter-observer agreement study for anorectal manometry coming soon to a computer near you. So thank you very much for your time and your input. And I'd like to bring this first part of the panel discussion to an end. After the next presentations are given, Maura Corsetti will be talking about the clinical application of investigations to assess continence problems and constipation. Thank you.